Okay, so now we're going to talk about newborn nutrition. So the newborn needs. So newborns require from either breast milk or formula, they require calories, they require nutrients, which come from carbohydrates and proteins and fats, and they require water, because infants can easily lose water from their skin, their kidneys, and their intestines. So where do these calories come from? Well, the full-term infant requires, if they are a breastfed infant, an average of about 85 to 100 kilocalories per kilogram of their body weight each day. A infant requires from formula feeding an average of about 100 to 110 kilocalories per kilogram. And breast milk and formulas usually contain about 20 kilocalories per kilogram. So we just said that newborns can lose a lot of their water. They can actually lose up to 10% of their birth weight as well due to this loss of extracellular water and consuming less calories than they actually need. They will typically gain this weight back within 2 weeks, but we expect this weight loss initially. So we will do daily weights on our newborns in the nursery just to see that they're not losing anything more than that 10%, because that could be really detrimental for them. So we want to make sure that they're staying within that range, but we do expect them to have some weight loss from their initial birth weight. In breast milk, the composition will change over time in 3 distinct phases. They're called lactogenesis 1, lactogenesis 2, and lactogenesis 3. In lactogenesis 1, this begins during pregnancy up to a few days after birth. So women may notice that they are secreting a little bit of colostrum even while still being pregnant due to the hormones that are responsible for producing this colostrum. So it can begin during that late stage of pregnancy up to a few days after birth. This is where the breasts secrete this colostrum. Colostrum is high in proteins, vitamins, and minerals, and it has all those really good immunoglobulins, those IgAs we talked about that help protect the gut and set you up for, a healthy immune system. It helps prevent, we talked about the sudden infant death that helps reduce allergies. So this kind of sets you up for these IgAs. It protects the infant's GI tract by establishing a good normal flora in that GI tract, as well as providing that laxative effect for the passage of the meconium, which, remember, contains those broken down bilirubin byproducts and helps you excrete them to reduce the amount of jaundice that will occur. In lactogenesis 2, this begins about 2 to 3 days after birth, and it is called transitional milk. So this is when colostrum becomes transitional milk, and you will notice an increase in the amount of fat and calories and volume that is in this transitional milk as compared to the colostrum. So eventually this will transition into mature milk. So the amount of the volume itself increases. So if you were to pump the breast when they have colostrum in it, as opposed to when they have transitional or mature milk, you'll notice that there's a definite increase in volume. There's also an increase in the fats and the calories. However, there starts to become a little bit of a decrease in the immunoglobulins and the protein. So this is important to understand, that if someone is going to breastfeed, the most important time for them to breastfeed is those first few weeks, or at least those first few days when colostrum is really high in those immunoglobulins. If you want to set them up with that good normal flora and that good immune system, those first few days are crucial. Now, it also continues to have many benefits as it turns into mature milk as well, and this is where the lactose and the fat and the calories all increase in this milk as well. In lactogenesis 3, this happens sometime within those 10 days. The color changes. It's a bluish in color and it's a little thinner. So again, if you were to pump it, it would look a little bit different. So colostrum initially, when you pump it, it has a yellow gold color to it. It's often referred to as liquid gold because this has got all those rich nutrients and IgAs. The transitional milk looks a little bit more like formula or milk, and then this lactogenesis 3, when you're in this mature milk, it does have a little bluish tinge to it when you pump it. This is what is actually containing those 20 kilocalories per ounce if you were to pump it. So breast milk, we know it contains proteins, carbohydrates, vitamins, fats, enzymes, infection-preventing components, those IgAs, those immunoglobulins, and antibodies. So what are IgAs? These are important protection of the newborn's GI tract and respiratory system. It's found in colostrum and breast milk, and breastfeeding babies have that advantage of that extra immunity over those that are fed by formula. Otherwise, they will eventually be produced by the newborn around 2 weeks old. Well, they'll start to produce their own immunoglobulins and their own immune system, but the colostrum gives them a jump start on this and gives them a little bit more than they would get from just producing their own. So what do we need to know about maternal nutrition? Well, mothers must maintain healthy eating and energy levels to support breastfeeding. It is recommended that they not engage in drinking alcohol while breastfeeding, but there has been studies that have shown an occasional glass of alcohol has not been found to be harmful to breast milk babies or breastfed babies. A lot of the recommendations are, and a lot of moms choose to do what we call pump and dump, which means that if they do choose to engage in having a glass of alcohol, they can then, the next time they were to pump, they actually just dump that breast milk. And then by that time, the alcohol is out of their system when they're ready to go ahead and pump or breastfeed the next time. So this is one of the options you can do, but they have found that an occasional glass is not harmful. Maternal nutrition is important in maintaining the health of the mom and the baby and energy for mom. So it's been shown that breastfeeding can burn the calories equivalent to what you would burn running a marathon. So it does require an extreme amount of energy to breastfeed. So your body is constantly making milk, producing milk, expressing it, and then making it again. So it's burning calories as they do that. It's another reason why a lot of women choose to breastfeed, because you do lose the baby weight a little quicker in breastfeeding because of the rate that you're burning calories just by producing milk. So the amounts of breast milk. In day one, it's about 5 to 7 milliliters, which is about 1 to 1.5 teaspoons per feeding. And we remember in that first newborn slide, the normal newborn slides, we showed you the different sizes of their stomach, and we showed you the different amounts in the bottles if they were pumped, what that looks like. Initially, because that colostrum does not have high volume, you're feeding more frequently. So you're going to be doing about 8 to 12 feedings a day. You'll see that newborn, and again, this isn't just day one, that baby will have about 1 to 2 wet diapers in that 24-hour period, and maybe 1 to 2 dirty diapers, or what we call those first meconium, which is that dark tarry meconium. By day 3, you'll see an increase, and remember, this is just about the time that colostrum is now transitioning into transitional and then eventually mature milk. You will see that the volume increases. Babies are taking between 22 and 27 milliliters per feeding. They're feeding about 8 to 12 feedings a day. You'll see an increase in their wet and dirty diapers to about 3 in a 24-hour period. And you may even see the stool start to change. You're going to see that they're going to turn into this yellow sticky stool. This is what we call transitional stool. We're going to talk about that more at the end of these slides. But you will see that as the components of the breast milk change, so does the stool that you see in the infant. By week 1, it's increased now to about 45 to 60 milliliters, or 1.5 to 2 ounces per feeding. You're going to see again that we're doing about 8 to 12 feedings a day. Their increase in their wet diapers gets significant. It's about 6 to 8 wet diapers in a 24-hour period, and about 3 to 5 dirty diapers in a 24-hour period. And again, this is now going to turn to a different stool, which is the soft, seedy transitional stool. In the first 2 weeks, we're now up to about 2.5 ounces or more per feeding. You're going to see the decrease in the amount of feedings to about 8 in a 24-hour period. You're still going to see those 6 to 8 wet diapers and those 3 to 5 dirty diapers within that 24-hour period. And again, the stool will look yellow, soft, and seedy. So how do we educate our moms to store breast milk if they choose to pump it and store it? So if your breast milk is frozen, it needs to be thawed overnight in a refrigerator. It cannot just be left in like a counter. Thawed milk is safe for 24 hours. So once that milk is thawed, you should use it in a 24-hour period. It is never okay to microwave. So we say that about formula as well as breast milk. Never microwave because it will have hot spots in it and can potentially burn the infant. Freshly expressed breast milk, or what we call EBM, at room temperature is good for 10 hours. So if a mom were to pump it into a bottle, she could leave it out in room temperature for 10 hours before she gives it to the infant. It does not need to immediately go in a refrigerator. If it is in a refrigerator, we tell our moms that that is good for 8 days in just a regular refrigerator. And in a freezer, it could be good for up to 3 to 12 months, depending if it's a regular freezer or a deep freezer, which holds things a little colder. When we're educating our moms about formula, we tell them that formulas are designed to be artificial breast milk. So manufacturers will try to mimic the components in breast milk as best they can, but they have never been able to copy it completely. It's very difficult to mimic breast milk exactly and the composition, because the composition of breast milk changes not only per day and per week, but it also will change on how much your baby takes, is the amount that your body makes. It can be changed on different levels. There have been even studies that show there's different breast milk composition whether or not you're breastfeeding a male baby versus a female baby. So it's difficult to constantly be manufacturing different types of formula to mimic the different stages that breast milk goes through. And when they do come up with formulas, these can be based on cow's milk or soy, and they do like a high calorie version for our preemies or our premature infants because they require a higher calorie at each feeding. So formula preparation. Babies need, like we said, about 100 calories per kilogram per day. So we need to teach proper mixing and storing of formula. We tell our moms to store unopened containers at room temperature, that they need to use it by the expiration date printed on the formula package. They need to feed or refrigerate prepared formula immediately. So unlike pumped breast milk, where it could sit out in room temperature for about 10 hours, formula needs to either be given immediately or immediately put in a refrigerator. And it needs to be discarded if not used or finished after an hour. So I believe we talked earlier about how their bacteria can form on the nipple after about an hour. So you really want to discard any unused amount of formula after that an hour that it's been prepared. So this is neonatal math that you will need to know for your exam. So these are the conversions I want you to know, that in our neonatal math, 1 pound is equal to 454 grams, 1 ounce is equal to 28 grams, and 1 inch is equal to 2.54 centimeters. So this is an example of a neonatal feeding math problem that you will see on your exam. So for example, baby Martin weighs 7 pounds 6 ounces. First, we need to know what is his weight in grams. So we need to convert it. So we remember that 1 pound equals 454 grams and 1 ounce equals 28 grams. That's from the slide before. So we take the 7 pounds times the 454 grams, and that equals 3,178. Then we add to that the 6 ounces. So we take 6 times the 28 grams, and that equals 168. So when you add the 3,178 plus the 168, you get 3,346 grams. So that's how many grams baby Martin weighs as the 7 pounds 6 ounces. That's what it converts to. Now we need to convert this grams into kilograms. So in order to do that, we need to divide that number by 1,000. So we know that baby Martin weighs 3.346 kilograms. So we move on to the continuation of that problem. If a baby requires 100 calories per kilogram per day, what is baby Martin's caloric needs? Well, we know he weighs 3.346 kilograms. We times that by the 100 calories that is required, and we know he requires now 334.6 calories a day. But what does that mean when we're feeding them in ounces? So let's figure out that if a regular formula has about 20 calories per ounce, we take that 334.6 calories that he requires a day, and we divide it by the 20, and we get 16.73 ounces a day. So that's about how many ounces baby Martin requires in a day. But now we need to figure out what he requires per feeding. So if baby Martin eats every 3 hours, how many ounces will he need at each feeding? Well, we take the 24 hours that are in a day and we divide it by 3 because he's eating every 3 hours. So that means that he is eating 8 feedings a day. So we take that 16.73 ounces that he needs every day and we divide it equally among the 8 feedings that he's going to do. And so we know now that he will take or will require about 2.09125 ounces per feed. And then we're going to round that to the nearest tenth. So he will require 2.1 ounces per feeding. And that's how you do the neonatal math when it comes to formula feeding. So another conversion you may need to know for your test is if baby Martin is 20.5 inches long, what is his length in centimeters? This is a simple one. We know that 1 inch equals 2.54 centimeters. So we take his 20.50, which is 20.5 inches. We times it by the 2.54 centimeters, and that equals 52.07 centimeters. We will round that to the nearest tenth, and so he is 52.1 centimeters. So those are the two maths you're going to need to know for your first exam. So now we're talking about factors influencing choice. So why do people choose to breastfeed or bottle feed? What are the reasons that help them make their decision? Well, sometimes it's an embarrassment or a comfort level. Some people are not comfortable breastfeeding in front of others or public settings. Some people need to go back to work right away and maybe do not have the ability to pump at work and to continue the breastfeeding with that. You may have a non-supportive partner or family. There may be family members that don't agree with that choice, and so you really do need a good support system if you choose to breastfeed because it does take a lot of work and effort. It could be a culture or a religion thing. There are some cultures that don't believe in breastfeeding or don't believe that breastfeeding is appropriate for the first few days. So whereas I'm talking about colostrum being liquid gold, there are some cultures that believe colostrum is what they call dirty milk, and they will purposely avoid feeding their infants by breast for the first few days until that colostrum changes into mature milk, and then they'll start feeding. And that's a cultural preference. It could be their amount of knowledge or education. Maybe they don't have a lot of education on breastfeeding, so they don't really understand a lot about it. It could be a bad past experience. If you had a mom who had difficult breastfeeding experience from another child, she maybe have suffered some injuries herself, like cracked or bleeding nipples, or maybe she had mastitis, which is an infection that can occur. Maybe the baby was a poor latch or a poor sucker, and she had difficulty getting this baby to feed. It could be that her physically has some issues. If a mom has a flat or an inverted nipple, it is more difficult for the baby to latch onto and feed. And so that can be one of the stumbling blocks to getting a mom to try to breastfeed. There are things we can do for that, which I'll describe here in these later slides, just to let you know about that. Babies, again, with a poor latch or a poor suck, it could be that it's just their reflex is not strong. Maybe they were born early. Maybe they have some other congenital defects like a cleft lip or cleft palate that doesn't allow them to latch properly. So we need to be non-judgmental, but always educational and always supportive in whatever their choice is. So there are different hormones that will change that affect breastfeeding. So once you've delivered the baby, you've also, after the baby is delivered, you deliver your placenta. And the loss of placenta and all of its hormones that are in that placenta will increase in prolactin, which stimulates milk production. So when you lose the placenta, prolactin increases, and this is what stimulates your body to produce milk. The sucking is also increasing the prolactin levels. So the reflex of sucking from the baby onto the nipple is another increase in those prolactin levels. And then oxytocin is the hormone that increases when the nipple is stimulated. And this is what causes the milk to actually eject and let down in the breast. So the hormones, the prolactin hormones, will bring the levels up to produce the milk, and the oxytocin increases whenever the nipple is stimulated, and it's stimulated by the sucking of the infant. That's what causes the milk to what we call let down, which means come from those back ducts to the nipple and then to eject out of the nipple. And it's a supply and demand. The more the baby feeds, the more the body produces these hormones, and the more the hormones produce, the more milk they produce, and the more milk they eject. So it's just supply and demand. The more your baby feeds, the more you'll make, and the less your baby feeds, the less you'll make. So how do we wean or teach our moms how to wean off of breastfeeding once they've chosen to stop? So those who choose to bottle feed and maybe not even start breastfeeding in the beginning at all, or if you've breastfed for a short period of time and now you want to stop, you're going to need to suppress that supply and demand chain. You need to suppress the production of breast milk. So there are different ways to do that. We always encourage our moms when they're ready to do that to wear a tight sports bra. The tighter you wear it, sometimes even an ACE bandage wrapped around, prevents the nipples from getting stimulated, which prevents oxytocin to be increased, which prevents the milk to be let down and ejected. We also recommend cabbage leaves. Cabbage leaves work very well. It's a natural remedy to help dry up milk. So we have moms just put a head of cabbage in the refrigerator. We tell them to take a leaf out, put it inside their nursing bra and against their breast, and it will help start to dry up that breast milk. Again, we want to avoid nipple stimulation, so you want to avoid facing the hot water of the shower. That can stimulate the breasts. We can encourage that they take Motrin for both the swelling of the breast as well as the uncomfortableness that comes with trying to wean, and ice packs for the same reason. It can definitely be uncomfortable. When that milk comes in, it takes a good 3 to 5 days before the brain gets the message that you no longer want the body to stop producing milk. You want them to stop producing milk. So it takes a little bit of time, and during that time it's uncomfortable. The breasts get very full, they get very heavy, they get very taut, and it can be incredibly uncomfortable, especially if you cannot alleviate that because you don't want to do anything that ejects the milk out, because once you do, the body will just make more again. So these are different ways we can help our moms either suppress the breast milk that will naturally come in the beginning, right after delivery, or if they're going to wean. Because remember, the body is designed to produce breast milk after the pregnancy. So it doesn't know that the mother's choosing to formula feed. So it's just going to go ahead and produce breast milk like it's supposed to do. And it's these things that you do that will help suppress it so that they don't produce any more milk. But you can't stop them from the get-go producing milk. It'll do it automatically. So the teaching and the assessment of breastfeeding. So when we talk about a latch, we're talking about how the baby latches on, or how the baby actually puts the nipple into their mouth. So there's something called a latch score, and we do it in a 0 to 2 in 5 different areas. We talk about how they latch, how their swallow is, the type of nipples mom has, the comfort of mom, and the positioning of baby. So it's important for a proper latch that the baby's mouth is open as wide as possible and takes as much of the areola in as possible. So big open wide mouth onto mom's nipple, taking as much of the areola as possible. Once they are on, you can hear, or you may even see, you can hear audible swallowing or see the facial muscles swallowing, sucking and swallowing. So we know that they've got a good latch. We can see that they're actually taking milk in and swallowing it. Nipples should be soft, everted, meaning that they are out, and free of damage. So is mom in pain while nursing? This is important to understand. Initially, when mom is breastfeeding, it can be uncomfortable. It can be uncomfortable in the fact that babies get on, they're sucking. I always tell my moms when I'm working that they almost have to have the nipples toughen up a little bit before it doesn't feel uncomfortable anymore. However, mom should never feel pain. There is a difference between being uncomfortable and being in pain. If a mom is truly in pain while she's breastfeeding, then the latch is not proper, and the baby is pulling or sucking on the nipple improperly, which is causing the mom pain and possibly damage to the nipples. So the breastfeeding latch, when the baby's gums latch to mom's nipple and areola, and they are properly in baby's mouth, the nipple is automatically drawn toward the back of the mouth. So what do we know about the posterior part of the tongue? We know that that reflex, when the posterior part of the tongue is touched, is to suck. So the nipple is drawn back so the top of that, or the tip of that nipple, actually touches the posterior part of their tongue. While that's occurring, The gums that are over the areola are actually compressing the ducts of the breast milk and helping to release that milk. So it's smooth, continuous sucks with pausing moments. That's normal. Babies are going to suck and suck and swallow and pause, and that's a normal, smooth, rhythmic way that they do this. So this is the perfect latch. So notice where the baby is angled under mom's breasts. Notice in the second photo, the mouth is nice and wide. By the third photo, that mouth stays open and mom brings her breast to baby baby to breast. And then that baby latches on. And then when that baby is latched, that's what that baby should look like. Notice the lips aren't pursed or they're not sucking close together. If that were happening, the baby doesn't have enough of the areola in its mouth. That mouth has to stay wide open like that. So there are different breastfeeding positions we teach our moms. These can be preference that mom has for feeding, or sometimes babies have preferences. Sometimes babies just feed better for whatever reason in certain positions. So there's 4 common ones. They're called the football, the cradle, the cross cradle, and the side lying. So those are what these look like. So all can be done by sitting up. That side lying can be done obviously while lying on your side. So I would say your most common are your cradle and your cross cradle, where baby's just right in front of you and you're supporting the baby's head and your breasts. The football hold is a good one if your baby is getting bigger, because the legs can kind of go behind you and they don't kind of fall off the pillow that way. It's also good if you need to stand and breastfeed. The side lie or the football hold is kind of a good one. And the side lying is nice if you are breastfeeding at night. It doesn't require you to sit up or get out of bed. You can do it while lying down. It's also a good one for our mothers who've had cesarean sections. Notice the 3 other holds, they have to kind of hold them near or on their belly. So if they have a cesarean scar, it can be very painful to hold anything across that. So we often recommend the side lying ones for our moms who've had recent abdominal surgery. So these are 2 videos. I'm not going to play them now. They're both showing you proper latches and proper breastfeeding cues. So take time to go back into your PowerPoints and click on these links. They're really good visual videos on how to breastfeed infants and how to teach proper breastfeeding to your patients. So now we're going to talk about signs of breastfeeding problems. So these could be some things that we need to troubleshoot that can happen when a mom is trying to initially try to breastfeed her infant. So the baby can be too sleepy or refuse to eat. Remember when we talked about in the normal newborn that they have those transition periods. So there's that second period of restorative sleep where they're in that deep sleep. This would be a very sleepy time that they have no interest in feeding. They can be what we call tongue thrusters, where instead of doing the proper latch and suck with their tongue, they're actually pushing it out like that extrusion reflex, and they're thrusting out the nipple rather than drawing it in. They can have a tight frenulum, or what we call tongue-tied, where there's a little piece of skin that connects the tongue to the base of the mouth that some babies are born with. That doesn't allow them to stick the tongue out completely to get underneath that nipple. So that will need to be what we call cut or snipped. And that can be done in the hospital to allow a better free range motion of the tongue. They could be smacking their lips or dimpling their cheeks. Those are all signs that they do not have a proper latch. Their mouth may not be open wide enough. We saw from those earlier pictures that that mouth needs to be open up really wide, as well as that lower lip needs to be turned out. So if you see a lower lip turned in, that could be an improper latch. They can make a chomping motion. So some babies will bite or chomp as opposed to swallow. That's not going to elicit the suck reflex or the release of the milk from the ducts. You don't want to hear audible swallowing. So earlier I said that you could maybe hear, if you don't hear audible swallowing, that can be bad. You don't want to hear audible sucking. If you can hear them suck, then they don't have enough of the areola in their mouth, and they're making a noise that tells you that they're just holding the tip of the nipple and they don't have a proper latch. However, you should be able to hear an audible swallowing. So if you don't hear one, they may not be getting the milk in and swallowing it down. And then there's also something called nipple confusion, which means that the baby will place their tongue differently on mom's nipple as opposed to a nipple of a formula bottle or of a pacifier. And this is one of the reasons why they recommend that you do not introduce a pacifier to a breastfeeding baby until breastfeeding is well established, because babies can get confused if they switch back and forth from a breast to a pacifier on where to place their tongue. And if they get confused, they might struggle every time it's time to breastfeed to remember where to put that tongue. So again, these are some other videos about ineffective breastfeeding. So take your time to go back in those PowerPoints and watch those videos on what can happen with ineffective breastfeeding and how you can troubleshoot that. So we're going to look for also abnormal signs that there might be some things going on with mom's breasts during this time. So the first one we're going to talk about is engorgement. Engorgement is when the breasts become hard, the skin is taut and very shiny. It can be extremely tender and somewhat painful. And this comes from not emptying the breast completely. So this could be either that mom is just producing way more milk than baby requires. And sometimes that can be a ethnic thing. There are certain ethnicities that just tend to produce more breast milk than others. It has nothing to do with the size of the breasts. And the other thing is that the baby may not be a good feeder. Maybe the baby doesn't do a complete feed or has a poor suck or latch and it just does a little bit at a time. If it's not feeding enough, then your breasts are getting full and you're not getting that chance to empty it, and that can be engorgement. So the treatment for engorgement is just to have mom apply moist heat to the breast. She can gently massage between the baby's sucking to kind of help push that milk out. Another condition that can occur is called mastitis. This is an infection of the breast ducts. So what happens is that the most common cause of mastitis is thrush, and that's thrush that commonly occurs in newborns. So when a baby has thrush on their tongue, if mom has any kind of opening to her milk ducts, meaning that the nipple has any cracks in it or blisters or bleeding, that thrush can then pass through mom's nipple into her breast tissue, into that milk duct, causing an infection in that milk duct. This is an extremely painful infection. It will make the mom feel like she has probably one of the worst flus she's ever had. Like I've had patients say it feels like a Mack truck hit you. It's hard to get out of bed. You have high fevers. You have an overall feeling of fatigue and soreness across the body. You have specifically warmth, tenderness, and pain in the breast it affects. Notice up on the picture there, it's very specific to one area where that redness is. It's often in the shape of a pie wedge. It's going to show you exactly what milk duct is infected, because that's exactly where it's going to get red on the breast. You have to get treated for this, and the treatment is an antibiotic for you, and sometimes nystatin for baby if the baby's carrying the thrush, so we're treating both the baby and mom at the same time. However, you will continue to breastfeed through this. Although it is uncomfortable, what you're doing by continuing to breastfeed, one, you're emptying the milk ducts from that infected duct, so you're kind of keeping the milk flowing. But the other thing you're doing is, as your body's trying to fight this infection, you're creating antibodies as well as what you're getting from the antibiotic, and then you're passing that immunity onto your babies through the breast milk. So you want to continue to breastfeed. We also want to look for abnormal signs as far as nipple damage goes. If a baby latches improperly, they can do a lot of damage to the nipples because that is a very delicate tissue. So that nipple damage could include cracked, bleeding, bruised, blistered, creased, reddened, or just sore. And those are nipples in the picture there where they are cracked and bleeding. So the treatments for those can be lanolin that we can have mom put right on her breasts. It's all natural, so mom doesn't have to wipe it off. Babies can breastfeed right with the lanolin on. She can use something called gel pads, which have a soothing component to it that helps heal those. She can use something called nipple shells, which you put inside the bra to keep the material of the bra off of the nipple so it doesn't stick to where it's bleeding. It kind of gives you a little air passage between the nipple and the clothing. And then air exposure. So we often recommend to moms that after they're done breastfeeding, leave the breast exposed to air for just a few minutes afterwards. that colostrum that's left on the nipple kind of acts as a protective coating around there, and by air drying it, it allows it to heal better to that air exposure. So going back to what we talked about nipple confusion, the La Leche League is the #1 league when it comes to breastfeeding, and they do all the recommendations and studies on breastfeeding. They recommend no pacifiers or artificial nipples be used until breastfeeding is well established. And as we talked about earlier, that's about a month, between 2 to 4 weeks before a baby has well established breastfeeding skills. Nipple confusion can be difficult because, again, the different tongue movements used in the breastfeeding versus the artificial nipple. And later, pacifiers are recommended by the American Academy of Pediatrics for the prevention of SIDS. So what they're saying is that because SIDS, or sudden infant death syndrome, tends to peak about the 2nd month of life, that 1st month they're really not at risk for it. So while they're establishing good breastfeeding, they recommend no pacifiers. But after they've established it, 2 to 4 weeks in, and now that the SIDS risk becomes a bigger risk factor at about the 2nd month, the American Academy of Pediatrics does recommending giving the baby a pacifier at that time, because there have been studies shown to find that babies who go to bed with pacifiers have a less likely risk of SIDS. So we talked earlier about newborn stools and how those will change in the amount as well as their color and consistency as they get older and as the breast milk components change as well. So this is just a scale. The numbers might be slightly different than what I showed on my slides. You don't have to memorize this actual scale yourself, but I just wanted to show you what we're looking at in terms of how by every day you're looking at different amounts and different colors and consistencies. So what do we know about infant stool? Well, at birth we know it's meconium. And meconium is stringy, it's tenacious, it's black, it's tarry texture. It's kind of very hard to wipe off when the infant poops. It's a very, very thick, tarry component. And that, remember, is what usually will contain a lot of that bilirubin that was broken down from those red blood cells. So ingestion of colostrum or formula will gradually transition the stool from that meconium to now what we call transitional stool. And this will have greenish stools that will gradually become more of a yellow color. In early infancy, the stool will change again, and it will change depending if the baby is being formula fed versus being breastfed. So in early infancy, the stools of a formula fed baby are what we call lemon yellow color. They're soft and they're more frequent. In the early infancy of the baby who's being breastfed will eventually become more yellow-orange color and be more of a curdy texture. So this is a picture of a meconium in a diaper. So as you can see, dark black, thick, tarry, stringy. So this first stool is excreted by the newborn. It usually passes within the first 12 to 24 hours of life. The absence of the meconium passage can signify an obstruction. So if you have not seen the first meconium within 24 hours, there's concern there that there's maybe an obstruction in the GI tract why this baby is not passing this meconium. Breastfeeding, again, has that laxative tool that helps passage of the meconium. And this meconium will consist of particles that are ingested during the time that the infant spent in utero. So this meconium will contain amniotic fluid, vernix, epithelial cells, hair, lanugo, bile, and water, as well as the byproduct breakdown of the bilirubin. The transitional stool is a combination of what's left over from meconium and milk stools. Notice this is green to brown and it's at a looser consistency. Milk stools, the color and the consistency will depend on the type of feeding. So we talked about this in that early infancy. If you're breastfeeding, the stool will often look what we call seedy or mustard colored, and we say that it has a sweet to sour smell, and it's more frequent stools initially with breastfeeding. If you're bottle feeding, it becomes a pale yellow to light brown, and it's the characteristic smell of feces and firmer in consistency. So not that any stool smells good, but the breastfeeding stool will smell sweeter than the formula-fed stool. And that is the end of newborn nutrition.